mm square for the left main, and 6 mm square and 5 for the circumflex, respectively. So the clinical benefits of IVUS-guided PCI was actually seen in Ultimate, a randomized control all-comers trial. That was published about 2 years ago. So among about 1,450 patients and almost 2,000 lesions, 9 to 10% of which were actually left main lesions, and 25% were bifurcations. So the use of IVUS-guided PCI was significantly associated with a lower target vessel failure rate compared to angiographic-guided PCI as shown here. So among the criteria that was actually used by operators for optimal stent deployment was the use of a minimal lumen area in the stented segment of more than 5 mm square and no edge dissection involving the media with a length of more than 3 mm. And in this pooled analysis involving about 1,670 patients from 4 registries with left main lesions treated with DES, IVUS was actually associated with improved survival free of adverse events at 3 years. Yeah, showed here. So I just want to go through quickly 2 case examples that shows the use of IVUS. So the case 1, 73-year-old Malay lady with multiple risk factors and chronic renal impairment, admitted for NSTEMI with congestive cardiac failure, EF of 40%. And this is the angiogram that shows Mandina 111 bifurcation lesion with TIMI1 flow down to LAD in fact. Now the RCA, there was actually just mild to moderate disease. So I elected to predilate both the LAD and circumflex first with a 2O balloon, as shown here. And I run the IVUS down. As you can see, on the right-hand side of the screen, there is actually severe disease in the LAD, and actually moderate disease is circumflex and calcified left main as well. And in this case, I elected to do a double stent strategy because I was concerned about the disease in the osteocert, higher chance of hemodynamic compromise and beyond stenting. And also, in treating the side branch first, I used the following landing zone criteria: a reduced plaque burden, and landing zone that have the largest lumen and no troublemakers. In addition, I would like to cover the bifurcation at least about 6 to 8. Okay, excuse me, it seems to be progressing on its own. So I'd like to cover the bifurcation at least 6 to 8 mm from the proximal stent edge to the bifurcation carina to enable subsequent port with a short balloon. So in this double stent strategy here, I deployed a 2.25 stent from the circumflex and with minimal protrusion in the left main. And after post-dilating the side branch stent, I actually crushed it. And of course, before I crushed it, I actually removed the wire and the stent balloon from the circumflex. Subsequently, I recrossed the circumflex and did the first kissing balloon dilatation. And next, I proceeded to do the left main and the LAD. And this is me showing the landing zone for my mid-LAD stent, which was a 2.5 DES, showing again a large lumen, smaller plaque burden, and no troublemakers such as calcified plaque. And just showing the end results here from the left main to the LAD. All right, this was I think a 3.5 DES and the 2.5 DES. And I actually had to do a second recross into the circumflex at a port with a 4O. And this showing the results in the IVUS, showing a reasonably good expansion and no edge dissection and minimal malposition. Now my second case is a 55.
In the interest of time, we take a pause here.
Yep.
So that I can ask maybe the fellows in the galleries whether there's any clarification or questions at this moment. Anyone in the fellows have any questions to ask? There was some questions actually about putting a trap wire in the side branch. Any fear of the wire not coming up? Anyone has any experience of the wire being trapped that it doesn't come off? Brosley, any concerns?
Well, I think in the left main, or if the proximal main vessel is quite large, then the risk is actually non-existent. Even if you go and port it, you will be able to come out. Or if you feel that there's a resistance and you find that it will not move and your guide goes in, then the other way of doing it is just to put in a balloon or microcatheter inside the wire which is trapped, go as close as possible to the site where the stent is, And the fact that now the site where your catheter is now, the microcatheter is now, or balloon is not very close to the site of the lesion, and it's a small area, so you are able to then, by physics, pull out with very little force. So I've not had an experience of jail for a long, long time. As long as you know how you're dealing with, and and you know that the proximal vessel is quite big, and you shouldn't be able or be concerned about jailing the wire or not able to pull down the wire.
It's a matter of risk, I think, and sometimes it can happen if there's a lot of long length of jail wire, if it's wrapped around. Two, if it's a lot of calcification, and it's a very good center position, which you want, but basically you've entrapped the wire really well, and or you're restenting old stents. Maybe this metal on metal may increase the trapping of the wires. And Rosie mentioned using that trick of using the balloon on that trap wire. But if you're doing that, I would probably advise putting a balloon in the main part of the stent. In case you do have deformation of the stent, then you can actually inflate the stent up. Otherwise, you may find it very hard to go through again with a balloon in the main branch stent.
Again, excellent teaching points. Kevlab, can we go back to the Kevlab to see whether Aaron has any other conclusions for us? Before, I want to show you the live web lab and see what final point on the port, which I think is an important point to focus on, we can show before moving on. Because time is really running out, although it's been quite enjoyable. Can we go back to Aaron and Chiang? Obi-Wan, can we share Aaron and Chiang? If not, can we share the web lab, Sandeep or Yensan?
Which one? Web lab or what?
And also, hello?
Oh, it's going back to them now. Okay.
Yeah, we can hear Aaron, but we can't really see you guys. And whether you can show the web lab model. Okay, so
seems to, yep.
So Ning Yan, actually, you're wired without doing a port, right? Is that correct? So I want you to show the fellows what happens on the bench model if you have not done the port and you're wired through the side branch and you balloon through a non-ported vessel. So maybe you can show us the wiring again.
You can hear me, right?
Yeah, not very clear, but okay.
Okay, sure. So now we stented the so-called, the model into the live case, it's a circumflex into the left knee. So currently I have a balloon, it's a Paul balloon. Actually, I wanted to do a port, but
let's not do a port. Can you show what happens if you don't do a port? I think this again an important point to emphasize. Maybe you like to pull the side branch and try to wire into the other branch now. So oftentimes, I think even without doing a port, you can get a wire across. What you're not sure of, if you're not doing this maneuver and you're using another wire, is that the wire comes under the sand strut, which was demonstrated by Dr. Takashi earlier on. And in this case, I'll ask Ning Yan to dilate through this non-ported vessel and show you what it looks like, whether there's any issues.
Oh, is that me? I think they muted. I think they muted.
Chiang, you're not muted. Actually, we can hear you.
Try using a 1.5.
So you can see this. Firstly, if you don't port it, there is some problems with crossing, especially a square balloon across the sand strut. And you can potentially just destroy the stent. Can you push harder there to try to cross it?
Oh.
Okay, good.
Okay, what? 12, 24, 12, 14, 14, 16. Okay, down. Okay. 3.
So when you don't pot, I think the observation to me is that the osseum of the circ shifts when you try to dilate the side branch. And then you may get some stand strut that is not well covered. Sometimes you wire underneath the stand struts. And any other comments, Dr. Takashi or Sydney and the rest of the faculty?
Jack, can you hear me?
Yep, Aaron.
Yeah. I think even after pot, when you dilate the side branch, the opposite side of the stent still get pulled towards the carina. So the pot actually is just dilate the main branch stent struts, but not to prevent the crossing, the pulling of the opposite end, the stents opposite the carina actually. Yeah. So that's why in Culotte, some people advocate a double kiss. So that double kiss can actually push that back. Yeah. But my question is that after you put the stent in, again you stretch that part, and that carina can the stent opposite carina can move again after the second stent. Yeah. So it may or may not make any difference, I think. Yeah.
The discussion point, Jack, is about stent crossover. So there's some suggestion the data, like for left main, is just stent over. There's not a lot of disease in the circumflex. That's because anytime you dilate through a stent, you have a lot of stent distortion. And you have to watch that very carefully, and you have to correct it. To truly correct the whole thing, you have to stent a balloon across the entire deformed segment, deformated stent, and to correct it, which means basically across the whole bifurcation. Yeah, so it's a stent crossover kind of balloon, and so and then you have to correct it. So if you balloon the side branch, you have to then correct the stent distortion. That's one of those things we have to make sure we do. That's what Darren is saying.
Balloon down.
Yeah.
So as what Sydney talked about, you can see there's a lot of stent distortion every time you go up on the other angled branch.
So the pot is really designed for optimizing the proximal stent. So the stent distortion tends to occur just a bit distal on the opposite side when you dilate through the stent strut. So that can only be corrected if your balloon passes over that point to correct it. And so you can see that sometimes very obviously on your X-ray when you're looking at it. So you got to be very careful with that when you have a very big balloon across there, particularly if it's large. And you're right, the double kissing or the kissing balloon corrects it somewhat, but you have to be very careful about where you can destroy the pot. If the pot balloon is very far in to one of the branches, you cause the same problem. Yeah.
Rosalie, do you do a double kissing culotte?
Yes, Jack. I prefer double kissing culotte, and I find that subsequently the wiring and also the balloon crosses so much easier. So if I do a culotte, nowadays I usually do a double kissing culotte.
Okay. Then regards to Paul's point, do you guys think that there is a factual difference in proximal and distal wiring? Again,
Jack, definitely there is a difference between proximal and distal. If you wire the proximal, you create a carina in between the bifurcation at the bifurcation area. So obviously we need to try to get a distal one, but the thing is on angiogram is very difficult unless you can see the bifurcation very well. The only way to tell is using maybe IVUS or OCT to help you guide it. Yeah, but sometimes stent boost like just now angiogram on the angio can tell sort of roughly, but definitively I think OCT is probably the best. Yeah.
Jack, I personally like the ultra mini culotte, so I do a lot of that. So I tend to not need to do DK culotte.
Actually, Sydney, the way you can do a modified string technique is to put the stent down using a Zabo technique. That means you are pretty sure that the wire is inside the last struts of the stent.
I don't have a problem. I don't like the Zabo.
Yeah, the thing is
it's a bit dangerous. The Zabo is a bit dangerous for stent embolization.
Yeah, you're not sure whether you wire the stent struts or not. How do you show that for this string technique you actually wire the last stent struts? Sometimes you miss it and you create a converter in crush.
True. You may have a little bit hanging out, but you can't necessarily, if you don't do Zabo, you can't necessarily be sure you're in the last stent strut.
Correct, yeah.
Yeah, you're absolutely correct, but only a little bit is okay.
Yeah, Fahim, you want to say something?
I think, Aaron, if, Sydney, I mean, if you're going to do double kissing, Culotte, and all those kind of things, and in other words, adding to the steps, I think a DK crush is a much better technique that way. And there's randomized data that, at least in experienced hands, in randomized trials, it is the outcomes are better with DK crush versus Culotte. So I think if you're going to do something that adds more steps, probably a better approach is just to go straight into a DK crush. That's what my preference.
That's also a way to think about it. I just want to just highlight maybe on a pictorial diagram, if you can see the screen now, on this schematic I just drew. And to just explain what you mean by proximal and distal wiring for fellows sake. So you have what Aaron did, right? Present a stent in the left main to the more angulated branch, as suggested by Ross Lee. So now if you put a wire, you've done a port, and the port is important because it opens up the stent strut a bit more here. And if you can see, if my wire comes, and when you mean proximal or distal, it may be easier to think about the carina. So this is the carina we're talking about. And when you talk about proximal or distal, it just means that in Culotte, you want to wire close to the carina rather than away from the carina. If you wire away from the carina and you do a balloon dilatation, what happens is that you shift all these stent struts here, and you create a false carina by shifting the stent strut, which is demonstrated on the wet lab just now. If you wire distally, closer to the carina, as labeled, then when the balloon comes out, the stent strut is shifted in the opposite wall, and the entrance is large, and you don't have a false carina. So it's a simple way of thinking about proximal wire crossing, and you put another layer of stents here. So as you can see, this is truly Culotte, 2 more layers of stents, double layer. If you do wire again, proximal means away from the carina. Then when you dilate the balloon here, you're going to shift again stent strut to create a false carina. So you're trying as best as possible to wire distal and close to the carina. I mean, this is theory. You saw it on the wet lab that Dr. Takashi demonstrated. If you don't, you create a false carina. But again, factually, it's quite difficult to appreciate without doing any form of imaging. So
Jack, Jack, that was very good. And I think that we probably should refer to it as the carina rewire, because it's probably easier to understand. Proximal and distal gets confusing for everybody.
Yeah, I think.
And the other thing is that when you do stent boost and you do a provisional, if you do a kiss, you can sometimes on the stent boost or clear stent definitely see better coverage on the proximal part with the stent strut being elevated from the kissing balloon dilatation. And that's a very nice picture usually. And you can see that there's a lot more coverage from the stent strut being pushed on that side. So it looks really nice.
So a stent boost when the wire cross is a helpful technique, provided you get a good orthogonal view to make sure you're not misinterpreting the proximal and distal wire crossing. Thinking about distal wire crossing as closer to carina is also a good way in Culotte stenting and thinking about where the wire should cross on fluoroscopy. On imaging, I must say I'm not so experienced in trying to decipher whether the wire is crossed proximally or distally on imaging, except we have a 3D reconstruction on OCT. So I think, the fellows in the gallery has been a bit quiet. Do you think I can ask some questions from the fellows? Whether you guys have any questions? Any questions from the call-in fellows?
Jack, sometimes it's about what you think you ought to be doing, the most ideal versus what you can achieve. So I think that they should not be demoralized. If you can get a wire in and balloon it, you might be left with it. Maybe it doesn't translate into a nasty event. They may want to prolong their DAPT and just be more careful with the DAPT afterwards. But sometimes you just you struggle. And wherever you cross is where you cross. You may try it again, but maybe you can't achieve it. So I wouldn't get demoralized with it. It might get better.
Yeah, I think I agree with Sydney, because sometimes beggar cannot choose. So sometimes, if you can cross is very happy already. So yeah, I mean, angiographically is really difficult to see. I usually do a stent boost before I took out the last balloon to check how the stent structure look like. But if it doesn't look good, then it's too late anyway. So
I think it's also for the fellows important to remember that in DK crush, you're trying to cross proximally. So it's not distal.
Across the middle.
Yeah, ideally the middle, but you know, if you can get proximal, but certainly not the distal. And for DK crush, it's a completely different paradigm. So they have to sort of remember what technique they're using and then where they need to cross, at least theoretically.
Yeah, DK crush is the opposite, so it's confusing. Okay.
Jack, before I can, before you end, I just 2 points, Disney. Number one is about the intertwining of wires. So just control your wire. You know, I see that a lot of people are using sometimes their nails and to be able to cross, but in doing so, you might actually twirl it too much. I tend to use a talker, especially when you're going to use a two-stand strategy and limit the amount of twisting of the wire. So that's one point. You know, one of the things I think this is because fellows course, I would still suggest for you to go for classical rather than a mini culotte or ultra like culotte, because you might just miss and by calculation and you will not get a culotte, and you probably might even end with a kissing crush if the stent is not adequately positioned in the proximal. So be comfortable first, and then subsequently you can be a Sydney low.
So I'm just going to go and in the last 10 minutes round the table to just give your teaching point again that you want the fellows to take back at the end of this course, starting from Dr. Takashi. Tell us a little bit about your teaching point to fellows after this Culotte session.
Okay, so my point is just two, pot and distal rewiring. But as discussed already, the distal rewiring is not always successful. But pot, everyone can do pot, right? Everyone can do the appropriate pot. So I think the pot is all fellows have to know the pot, and possibly distal rewiring. That's two.
Excellent. Dr. Fazila?
Yeah, so what I felt that there was quite a talk about twisting of the wires. So since it's a fellows course, I would think that the fellows need to, you know, take a deep breath and do one step at a time. So whatever you're doing, do it to the best of your effort. And about the twisting of the wires, what I find very useful is using a sterile napkin to place between two wires and not to touch my wires and to be gentle with them as possible. So that sort of lowers the incidence of twisting, and do a proper job of proximal optimization. And if I do a proper job of proximal optimization, I think my wire will go to the strut that it needs to go. And if I am having difficulty with that, microcatheters sometimes help us. So we go with a microcatheter, and if I need, I can change the tip of my wire subsequently to help it go where I want it to go.
Thank you. Dr. Jaw?
Yeah, my point is, you know, when you start this Culotte technique, you need to choose the right patient, and then be gentle as possible as whenever you cross the wire as well as you take out the wire, to avoid the wire passing under the stent strut, as well as the difficult to retake out the wire. So gentleness is the most important thing, and then the pot, the proximal optimization is the most important thing is the this bifurcation technique. Thank you.
Sydney?
Look, I think I agree with all those things, particularly need to prepare the lesion well, advise imaging if you can, and of course, NC balloons in both branches, and yeah, as precise as possible. I think that's one of those things I would like. So imaging helps that. And understanding the technique and that you can bail out from a provisional, I think that's great.
Rosalie, do you want to summarize the technique? Then we can just do some take-home message right at the end.
Right. Well, summarize. Well, the technique is fairly clear. I think what is important is for you to go through the steps in your mind and be very clear of one to the other, so that once you're very clear of the steps, then you would not falter that much during the actual procedure. Wiring both vessels, vessel preparation, and it has to be an adequate and appropriate vessel or lesion preparation, and then stent into one of the branches, and most times are not for the classical culotte into the angulated side branch. Remember to recross the stent struts. Before recrossing, of course, you need to pot, recross the stent struts, open the stent strut up, and then place in the stent in the main vessel, and then subsequently recrossing into the side branch, open up stent struts, and a kissing in two-stage procedure. The final kissing, well, before the final kissing, you have to make sure that ideally you go with a non-compliant balloon, high pressure, making sure that the stents are well expanded, and then end with the kissing at a fairly nominal pressure. And then a final pot if that is required. With imaging as an ideal way of ensuring that you get good results. So I believe that go through the procedure, choose the right patients, and just do it. Jack?
Yeah, can you hear me? Are you able to hear me?
Yep.
So I like the just do it part. I just do a quick summary, then I think we should close. Yeah, just checking that you can hear me correctly. Okay. So I think thanks everyone for participating in this session. I just want to highlight the fact that here we are addressing our fellows. So I just want to make it clear cut. I think first off, choosing the right patient, like what Dr. Joy and all this has emphasized, is very, very important. The right patient in this case means the patient shouldn't be, the first case is a high risk case. Doing a left main PCI is not what you're trying to do. Get someone senior to proctor you to do it properly so that the techniques is well refined. Don't compromise on the guider. If you get a complex case, just go on a bigger guider. Don't try to do something tricky here. Imaging is important. If you can use imaging and use imaging properly, try to use imaging. If for all bifurcation, you can just do simple provisional stenting. I would advise provisional stenting has the best outcome here. If you do have to end up with a two-stent strategy, decide carefully what is your comfort zone. I think in this case, it could have been done in a number of ways. The important point is pot. And then once you use a two-stent strategy, decide for yourself and be very clear in mind whether it's a proximal or distal wiring based on the technique they're using, whether it's a reverse culotte. And therefore, I think the confusion comes with fellow with the discomfort about securing side branch, whether it's a proximal or distal wiring. And I think in bifurcation, again, with a good port, you can be more sure with even fluoroscopy guidance of a distal or mid wiring closer to carina, expand out properly before two stents, final kissing, and a final port. IVUS helps in landmarking the length of all the stents that you use, the sizing, and ultimately the end result. As you can see, it's not 100% necessary, and sometimes it can cause more harm if it's not crossing properly, like in this case. So I'd like to thank everyone for participating in this workshop, and I would like to welcome you guys to join again if you are keen. I was supposed to have invited Rosalie to do it tomorrow, but tomorrow is polling day in Singapore, so it happens to be today. And we were supposed to do DK Crush in the morning and Culotte in the afternoon. So now we have to break it apart in two. Next month, we're going to do a DK Crush Fellows Workshop like this, clarifying the difference between DK Crush and Culotte next month. And I hope you guys can join us again. So with that, I'd like to thank all the participants, all the dialed-in fellows. Thank you for your time and patience for letting us do this on the first round basis. I'd like to thank my faculty and of course my patient and staff for contributing to this workshop. So I hope you have benefited, and please feel free to submit your feedback. Good and bad is welcome. So thank you very much for dialing in, and goodbye.
Thank you.
Thank you.
Thank you.
Guys.
Thank you.
Thank you.
Thanks, Jack. Well done. See you all.
Thank you.
Sydney.
Bye-bye.
Bye.
Thanks everyone. Bye-bye.
Thank you, everyone. Thank you. Bye-bye.
Bye.
Bye.